All right, good afternoon or good morning or somewhere in between. So I'm going to be talking about spinal-induced hypertension, this is basically kind of the end of this conference, and I hope you've had the opportunity to enjoy not only the conference but the surrounding area. So why is it an important topic? Well, the vast majority of cesarean deliveries are done with spinal anesthesia, and the vast majority of patients are going to experience hypotension when you do a spinal. And it has consequences both for the mom as well as for the baby. And all of these are well described in literature. And what is reassuring is that we can actually make a difference in this particular outcome. I'm going to go through a thorough evidence-based approach towards how we should manage these patients. I'm going to focus specifically on the objectives of fluid loading and what works, what doesn't work, and then look at vasopressor therapy to try and minimize this complication. I have a few financial disclosures, not really relevant for this, but I do consulting for Smiths Medical. I've got research grant from Covidian, and I will mention if there's any off-license disclosure of any drugs. So before you blindly follow every single thing I'm about to say, I just want to establish a few things. So the first thing is, with a round of hands, I want to know who preloads with some fluid prior to doing a spinal anesthetic for a cesarean. So show of hands. And keep your hands up if that fluid is a colloid. You can lower it if it's a crystalloid. Okay. And then in terms of the vasopressors that you use, a show of hands for phenylephrine, and a show of hands for ephedrine as your first line agent. All right. So you're not really alone there, but it's really interesting to see this particular audience, although it's a self-selected audience, because we obviously all have an interest in OB anesthesia already, in terms of the variation in practice. But a few years ago, when the Society of Obstetric Anesthesia membership was surveyed in terms of the utilization of various techniques to minimize spinal hypotension, they found that 2/3 preloaded, most of them with crystalloid, which is kind of what we got there. And there was a mix between ephedrine and phenylephrine. Actually, the majority was still using ephedrine. There's been a slow change in practice there. And the vast majority use bolus non-infusions to manage hypotension. So we'll see if this practice, or the practice that I witnessed for the show of hands, is actually a strong evidence base. And the first point of discussion is really the crystalloid colloid discussion and fluids per se. So it's interesting with a large amount of people utilizing preloading that it actually started in the 60s with Gertie Marx's landmark papers. And the study was methodologically flawed by modern standards. It would never have been accepted for peer review, but yet it completely changed practice. And the first thing they did was they had to show that fluid was even safe. So they put central lines in and gave patients up to 1 liter of fluid, because they realized pregnancy was a hypovolemic state and didn't want to cause harm. And then in 18 patients, this wasn't a randomized study, sequential allocation, in the 18 patients who got 1 liter of 5 DW, they had no hypotension. And you can see the other columns with ephedrine and the combination. And this single-handedly changed practice, because they were able to show women who experienced hypotension then had better cord blood gases, high APGAR scores, and babies breathed quicker. So this is a systematic review that's published a few years ago. That 45-degree line is where it makes no difference. If it goes off to the right, it's going to be favoring the control, and then to the left favoring treatment. So you can see that Gertie Marx study all the way up there. And that was what single-handedly changed the whole way we administer anesthesia with the preloading. The truth is they all hover around that 45-degree line. It doesn't really make much difference. And to date, the best study that's been done on this, the ROUT study, showed only a 10% reduction in the incidence of hypotension. So if you're going to use a preload, you can use it, but it doesn't seem to work that well. If you compare a crystalloid to a colloid, so this is the same slide looking at the studies with colloid preloading, you can see all of them showing, favoring the treatment group, showing definitely preference to a colloid. And if you update this was in 2001, with a more recent systematic review, the risk reduction of 0.68. So if you are going to preload, the most effective fluid to use is a colloid. However, as with any fluid that we have to deal with in day-to-day anesthesia practice, there is concerns about different fluids, and colloid is no exception. Now, there are advantages which I've just shown you from the systematic reviews: less hypotension, better cardiovascular stability, less vasopressor use, or less nausea and vomiting. But there are a lot of disadvantages. It is more expensive. There is a concern with anaphylaxis, although modern colloidal solutions have very low incidence. There is several cases of intractable pruritus. And now we have this FDA black box warning for concerns with renal or coagulation function, although when we study the coagulation function effects in our population, OB, they're very minor. But given this backdrop, most people have abandoned the use or limit the use of colloids routinely in all cases to prevent hypotension. So let's go back to the crystalloid. So the problem for the reason why crystalloid doesn't work so well as a preload is that it doesn't stay in circulation long enough. And this was a very clever study outside the OB population that had two groups, one which got the crystalloid at exactly the time of the spinal. So you can see that arrow where spinal anesthesia was, and in the dark column on the top is the Coload group. Now this is giving the fluid rapidly, so you use an arterial A-line bag and you squeeze it in as quick as possible. The quicker, the more effectively it works. And you can see in terms of measurement of cardiac output, you maintain it better with your Coload compared to the preload group that had the fall in cardiac output. So this gave birth to the concept of Coloading, and you'll hear a lot of it in the literature. Subsequent to that study, there's been several studies in the OB literature looking both at colloid and crystalloid. That's, do I preload, and then you compare the preload to a Coload technique, both with colloids and crystalloid. And you can see with the forest plot, that little diamond is pretty much right down the middle. It doesn't seem to make a difference. So if you look at the strong evidence we have, it suggests that coloading is as effective as preloading. So you do not have to delay surgery to get a prescribed amount of fluid in before you go ahead and do the spinal. Unnecessary to delay surgery, and this is particularly important in emergent situations. But regardless of all the studies looking at fluid, the efficacy of fluid use, the vast majority of patients still have hypertension and still require vasopressors. So fluid in isolation doesn't work very well, and we will discuss more why that is the case. If you're going to use a Coload, which is the best solution to use? And this study compared crystalloid versus colloid, Coloading, and found very little difference. So given this data, I would suggest just using a crystalloid Coload. And at Stanford, for many years, we used to use a preload of a colloid, and we've now transitioned to a Coloading with a crystalloid. And when we compared our data practice, we found slightly more hypotension, but really not clinically significant, a little bit more vasopressor use with the Coload compared to the crystalloid preload. So we've transitioned to Coloading with crystalloid. But if you want to preload, the best solution is a colloid. Now, we're talking about fluid. There's one thing getting the fluid in, but we have to get it into the heart. And left uterine displacement is obviously critical to this function. Although saying that, a recent Cochrane review found that there's no evidence to support the use of left uterine displacement. Saying that, this is a typical conclusion that Cochrane reports come up with because of the evidence they have, and the outcomes that they looked at and the level of studies that looked at it are somewhat weak, because we know very well that cardiac output can change significantly in the supine position. We know that for left uterine displacement to be effective, you really need a decent degree, at least 15 degrees. And it's not just the full population that benefit from left uterine displacement. 8% of the population have significant symptomatic supine hypertension, and it's those that you really have to benefit. You may have to do it in everyone to benefit that group of population. And before I leave fluid, just to briefly mention that another way of getting the fluids into the circulation is using leg compression devices. So a lot of us use TED hose or SEDs to prevent DVTs. Well, actually, it has an indirect benefit of minimizing spinal hypotension. And this is the same Cochrane review that I showed with the different fluid administration, showing a relative risk of 0.69. So definitely in the same ballpark of a preloading with a colloid. So worthwhile using. It doesn't matter difference between TEDs and SEDs. We looked at our practice, doesn't seem to make much of a difference. Just use something. All right, so if you think the shouting and the complaining and the controversy was a lot with the fluids, there is a lot more when it came to watch vasopressor. And I've learned something from my wife, which is the likelihood is the person on the right is probably the correct person. And I'll show you some reason why. So the reason why ephedrine even started becoming the drug of choice originally was based on sheep model studies. And lots of them were done, mainly in the 70s, because the feeling was a sheep placental model was very reflective, or a good model to reflect a human placental transfer and physiological effects. What happened with these studies is they drove blood pressures to supramaximal. So this wasn't correcting a spinal to get it back to normal. This is either a non-anesthetized sheep, where you're pushing the blood pressure up more and more, and clearly the alpha agonists were going to compromise uteroplacental perfusion. And even those that got anesthesia, they got general anesthesia, which is not pertinent to how we do our cesarean deliveries anymore. And we've subsequently realized the model isn't probably that good because there's a nitric oxide synthetase upregulation specifically in sheep, and we think ephedrine has some effect with releasing that, and therefore may explain some of the results. So what about humans? It was actually a very brave clinician who finally decided to say, I don't care what the sheep models show, I'm going to actually do the first clinical study. And the first study showed better pHs in the group that didn't receive ephedrine, so the phenylephrine. We've had several studies, and the meta-analysis that then followed, produced by Lee, but subsequently Cochrane review, showed this acidosis. But what it also showed is there was no real difference in maternal hypotension. Yes, you get more bradycardias with phenylephrine, but you also get more tachycardias with ephedrine. But there was definitely this repeated theme of acidosis. But let's put this acidosis in perspective. The weighted mean difference was 0.03. So it's not like you're killing every fetus by giving ephedrine. So ephedrine is a drug that you can use, but perhaps it's not the first-line agent, and I'll explain why later. Now, you do increase your acidosis risk 5-fold if you look across the board. And not only that, if you go one step further and look at what the effect is and what's going on, Warwick and Key did a very elegant study looking at drug transfer of ephedrine and phenylephrine, showing 5-fold increase of what drug gets across to affect the fetus. And then going back to what is causing this acidosis showed very clearly that it is creating this catabolic response within the fetus that starts to create this. And it may be okay in a fit, healthy, elective case, but in a distressed fetus, more reason why you would want to avoid a drug that not only is more likely to get into fetal circulation, but also to have this catabolic consequences. The main reason why you should use phenylephrine has nothing to do with the fetus. It's actually more to do with the mother. And if we go back to basic principles about what happens when you do a spinal. So if you do a spinal in an average patient, you're going to notice that the blood pressure on average is going to drop about 20%. So the question then is, what is driving this fall in blood pressure? And the primary driver is SVR reduction. It is an afterload problem, not a preload problem. And if you, on average, the SVR is going to drop 35%. Now these studies, which are landmark studies done by Dyer and Langesater out in Norway, look specifically at the cardiovascular changes with cardiac output monitoring. So we have very good insight now into exactly what happens, whereas before we were only focusing on blood pressure. But if you look at this change, you'll notice that the cardiac output actually increases. It's increasing in response to the SVR reduction, okay? So it may explain why the fluid augmentation, you can already see that the stroke volume is up 10%. So we're already augmenting our stroke volume. So the fluid administration clearly is not going to have as big effect as driving it through afterload reduction. So this is a very important slide. Remember, SVR goes down, but cardiac output goes up. Now that is in the average patient. There is a very small subselect of patients, and you heard about a few disasters already in the conference, that are going to have this. They're going to have hypotension and bradycardia. And this is a very different picture to that physiological picture I showed you. What this is, we think, is an exaggerated Benzol-Jarisch reflex because there's no fluid in the ventricle, and you get this exaggerated response. It could also be because of cardiac ciliary fibers in the setting of a high block. And in this setting, it is all about get fluid in as quickly as you can, get that ventricle as full as possible, either with Trendelenburg. Yes, Trendelenburg, even with a high block, because you've got to start filling up the ventricle. You can give chronotropes, and we're not sure which are the best, but you're going to throw in anticholinergics, ephedrine, epi, and phenylephrine is not contraindicated in this setting because it works quickly. It is a potent restorer of blood pressure, and it's important for maintaining coronary artery perfusion. So this is a very different setting to the one I showed you before, which the vast majority of patients are going to undertake. Now, going back to the Dyer paper, this is when he was comparing ephedrine and phenylephrine. You can see in the dotted line, that is the blood pressure. And one of the primary reasons why phenylephrine is a better agent is it rapidly restores blood pressure. You can see that line is almost near vertical. You can rapidly restore the blood pressure. But what you'll notice is the cardiac output and the heart rate going down, so in the black and in the gray. One of the problems with this publication is he never put in that red baseline pre-spinal. So what people thought is by giving phenylephrine, you're actually compromising cardiac output. But what it's basically doing is it's restoring it back to baseline. Remember I showed you it actually increases in response to a spinal? Well, it's just saying you no longer need to increase anymore because I've taken care of the SVR reduction. Does that make sense? So this is a very badly misinterpreted slide within the literature. So further to this, you'll notice that the heart rate and the cardiac output are going down in unison. And actually they showed very strong correlations between the heart rate and the cardiac output. So you now have a real-time cardiac output monitor in your operating room every day. It's your heart rate. And if you watch that heart rate, if the heart rate starts going up, you know there's a cardiac output response to your spinal, and you already should be treating the blood pressure before you even get the next blood pressure back. So we have a surrogate for cardiac output monitoring. So what should we do? We should maintain blood pressure as near normal as possible, and Warwick and Key did a very elegant study. Historically, we used to allow the blood pressure to drop 20 or 30% before we'd even give a drug. Now it's give it immediately and try and maintain it, mainly for maternal reasons, but there may be some fetal or neonatal reasons. And we discussed a little bit about the use of ephedrine and phenylephrine, but what about the use of an infusion as opposed to bolusing? And we now have fairly good evidence that an infusion is the way to go. So this is a recent meta-analysis looking at hypotension before delivery, significant reductions in the incidence of hypotension. If you compare the use of ephedrine and phenylephrine as infusion, again, phenylephrine is better. If you look at hypotension after delivery, it's better with a phenylephrine infusion, probably because it's offsetting the oxytocin effect. And that was shown also in the Dyer paper. And you can decrease nausea. So the use of a infusion definitely smooths out your anesthetic, minimizes the amount of hypertension, and we've transitioned over to routinely using the use of phenylephrine infusion. So what rate should you use? So a lot of the Warwick and Key papers, and he did a whole series of them, used 100. And the feeling was this was a little bit too much. And the problem was all those papers were focusing on blood pressure, not cardiac output. Because if you look at dose finding studies with what infusion to give, you notice with the higher 100 microgram per minute doses, you start to compromise cardiac output. So therefore, the recommendation is to start at about 25 to 50 mics per minute. So we'll start that. So you start your Coload, you start your infusion, and you virtually eliminate or significantly reduce the need to give your bolus doses to correct it. So prophylactic use of phenylephrine infusion. When it comes to a bolus, and you have to give a bolus, how much bolus should you give? And the answer is we have no idea. And in one attempt of the study, this is an effective dose 95 study where you subsequently change your dose based on the previous patient's responses. They reported 159 micrograms, but look at that confidence interval. I mean, close to almost 400 micrograms. So clearly, this is not what you're going to do. You're going to titrate to effect. Again, looking at the heart rate changes or the relative blood pressure changes, so 50 to 100. So for the last 3 minutes, I just want to switch to a few quick little topics to cover. So I was showing you population, and there's a move now towards, can we actually identify specific patients at risk? And there's a lot of work that's been done on this. Looking at patient demographics doesn't seem to predict it very well with sort of poor odds ratios. There's even an attempt to look at genetic predisposition, which does definitely show some preponderance for the fetus to get acidotic, but not really help us much in terms of maternal hypertension. And now there's new dynamic non-invasive monitorers, and there's utilization of those prior to the spinal to see who's at risk. But this is clearly not for commercial use yet, and I don't know if it'll ever really get there. Well, what you're going to see more and more of is these closed loop designs. So instead of starting your phenylephrine infusion on 50 micrograms per minute, it's going to be part of a real-time feedback closed loop. And Warwick Nankey, as well as Alex Sear's group, and a few others are starting to experiment with this. So it's changing real-time to blood pressure or heart rate, and eventually when we have cardiac output monitors, it can link it all. So you just hit play and then let it all take care of itself. So it is not commercially available yet, but this is going to change the way we do things. And I think what the new monitors have changed our practice is we never used to know cardiac output. We'd only focus on blood pressure. Now we're having better insight into what's happening with the cardiac output and how should I compromise it and how can I minimize that. Because one of the problems we know is pressure is very important to placental perfusion. But also cardiac output is for oxygen delivery. So there's a balance between both that is the driver. And still to this day, we're not sure which should be the primary driver, blood pressure or cardiac output, probably somewhere balanced in between. We certainly don't want to be compromising cardiac output. I'll also mention phenylephrine. This is hot off the press. Warwick Nankey spent over a decade convincing us we need to use phenylephrine, and along came this study saying actually norepinephrine is actually better. And he did a very eloquent study published recently in Anesthesiology, actually did the editorial. So I read a lot of the details of the study, and it's very provocative. It's interesting to think about taking this drug that we associate with sepsis and ICU care into a healthy population undergoing spinal. And it's mainly because of the beta effect that they were able to minimize those heart rate changes, but they were both equally effective in terms of maintaining blood pressure. I think the adoption is going to be problematic because this is a drug that we're not familiar with. I think it's a step too far, but we'll see what lands up happening. Probably if it was initially introduced as the drug instead of phenylephrine, we probably would be doing it today. The use of glycopyrrolate is, in the study that has looked at it, is not found it to be beneficial in terms of significantly preventing hypotension, and there's the nasty side effects associated with the anticholinergic. And there's interesting work done with ondansetron, because of the 5-HT3 receptors, intracardiac one, maybe it can prevent hypotension. 1 or 2 studies showing an effect, others showing not really an effect. So it's something that I don't personally utilize, but if you wanted to use it, you're welcome to use it. Remember, the half-life is about 3 times longer in the fetus of ondansetron, and there are some potential fetal effects like prolonging QT. So you must think a little bit about it. You're welcome to use it prior to delivery, but balance at least the dose that you're going to give. The one word of caution is do not change your anesthetic technique to try and minimize his effect. And this was started, and Bob D'Angelo mentioned it yesterday about this, but in one study they compared 5 milligrams of bupivacaine with fentanyl compared to 10 milligrams, trying to push this low-dose use of spinals, found a significant difference, and there's this hypertension incidence, 90 versus 30%. So it showed convincingly that this is the way you can eliminate hypertension. And I don't dispute these findings. One of the big problems is you introduce a much bigger problem than hypotension, which is block failure. And in studies that have used low doses, the range, depending on how you define block failure, is anything from 10 to 50%, which is totally unacceptable. And if you go one further and look at meta-analysis on the 2 that looked at low dose versus high dose, one making 8 milligrams the cutoff for low and high, and the other one 10 milligrams, showing significantly more requirement for analgesic support. And especially with a single shot technique where you really have little control once the needle comes out. The recommendation, certainly from the work we did and Bob mentioned, doses below 10 start to become unreliable and should be utilized as a combined spinal epidural technique. So take a message, don't drop your dose below 10, just with the purpose of trying to minimize hypertension. So that's a quick summary of everything. I hope I've emphasized the point that the primary driver of spinal hypertension that you'll see almost every day in the operating room when you do a spinal for a cesarean delivery is afterload driven, not necessarily preload driven. The body is actually trying to augment preload. So fluid can help that augmentation, but is not the primary driver behind spinal hypertension. If you're going to use a preload, use a colloid, because that's clearly the more effective one. But the better use of a crystalloid solution is to use it at the time of a spinal. So get it under pressure when you're doing the spinal, co-loading, get that liter in as quickly as possible. Interesting thing that we found is it actually gets your vasopressor in as quicker as well, because the carrier solution goes quicker. No matter what fluid you use, remember you got to get it to the heart, so left uterine displacement, leg compression devices, which you should start if you're doing SCDs as soon as you're doing the spinal. Don't wait till the patient's sat down and the catheter's in and everything else is done. I may not be able to convince you to start using a vasopressor infusion, but play around with it. It changed our practice. We've certainly moved over to it and utilize the boluses for rescue, which you'll have to do very few of. But phenylephrine is clearly the drug of choice. And with all this evidence and with all the management improvements, changing your anesthetic technique is not necessary, and I would strongly discourage low dose to minimize hypotension. So that's it. I'm going to end it right now, and I'll happily share all my slides with you if you want, although all of this is being recorded by the AIMS lab, so you'll be able to see it online. But if you want my slides, just email me at that. Thank you very much.